Mm. Fucking word. Hey. Testing, 1, 2. Testing. Can you hear me? Can you hear me? Can the panelists hear me? Hello? Testing, testing. Shanawa's Amma said, can you hear me? Testing, 1, 2, testing, 1, 2. Okay. Good. Hello, that's Juicy.
Hello, Mansour, are you there?
John, hi, can you hear me?
Yeah, I can hear you.
Wonderful. How are you?
Good, how are you?
I'm good. I've had some medical things to attend to with family and
Yeah,
A&E.
emergency room. Is the emergency room a zoo now?
No, actually, you get this video working. Bear with me.
Okay.
Is Rafid there? No.
I don't know.
Let me just make sure that he's. Bear with me. Hello, Rafid? Are you joining? Okay, bye. And can you see me, John?
Yeah, there we go.
Okay, great.
With Brighton, not Brighton. And you told me once. I forgot already.
Okay, no worries. Yeah, so no, I spent some time in A&E and with a relative virtually all day yesterday until early hours, and the staff were brilliant.
That's not a pleasant time.
No, absolutely. But the staff were just so good. It's a big test and challenge for everybody.
Yeah.
So.
Well, I didn't ask Atul because it turns out that's like 2 in the morning in India. So rather than waste my invitation, I said, well, I better wait. But you guys could get together, I'm sure, easily one time.
No.
A time of your choosing.
Sure. No, thank you. I think it's a difficult time for everybody to log in because maybe I should, for next one,
Yeah, Rafid's here.
Okay, great.
Okay, you ready to start?
Bear with me. We just make sure I've got.
You want to run a test or something? There's no hurry. We can do a test if you want to test your slides or something.
No, should be all right. Rafid, are you there?
Yeah.
Hi, how are you?
All right. Thanks.
Okay. Screen share to do. Why the colors is there?
You're trying to find the screen share?
I did so, but for some reason it wants to share the old presentation, which is very odd.
I don't see it. There you go. You're sharing now.
I'm sure.
There you go.
Sorry guys, bear with me.
Okay, do you feel comfortable or you want to leave it there or?
No, it's just a bit of a pain because I'm trying to operate the screen, but the thing just keep appearing exactly when I want to touch the other button.
Okay.
And I'm trying to just do a new share of.
Just click on the play now.
Can you see?
Yeah.
Can you see the presentation? Does it say key one malformation?
Yes.
Sorry, it just previously said keynote, and then it was saying colloid cyst. So.
Okay, why don't you rather than changing the screen and to introduce you, let's just start from leave it there, okay?
Sure.
And so we'll have to change the screen. It's no big deal. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good day. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today we're graced with the presence of Mansour Farohi. He's a London neurosurgeon. He's going to be presenting Chiari-1 malformation diagnosis and management. And first, let's try to go around and introduce a couple of the panelists. Hello, Rafid.
Hi, John. I'm Rafid Al-Mahfoud. Welcome, everyone. Neurosurgeon in Brighton and London. And I work closely with Mansour Farougi. He's got lots of experience with Chiari-1. He leads the our CSF MDT here in Brighton, and he's worked in Birmingham where a lot of these concepts started. So I'm sure he'll mention all of those. And yeah, welcome everyone.
Okay, very good. Rafiq, could you introduce yourself, please? The other Rafiq, another Rafiq.
Hi, John. Hi, everyone.
Hello.
Hello.
Yeah,
can you hear me?
hi. Yes.
Yeah, I'm Rafiq. I'm a young neurosurgeon from Algeria.
Okay, welcome.
Yeah, thank you.
Okay, Des Trucy? Can you hear me, Des Trucy? Go ahead.
Hello, everyone.
Go ahead.
Yeah, my name is Desterus Chus. I'm an ear, nose, and throat surgeon doctor, and I'm here to attend this session. Thank you very much.
Welcome. Abhinab, am I pronouncing it correctly? Perhaps not. Ahmed Farag.
Yes.
Yeah, hi. Could you introduce yourself,
Hi.
please?
Yes, good evening, everybody. I am Dr. Adil, originally from Egypt, but I am working in Saudi Arabia.
Okay, welcome. Gerald.
Yes, I found difficulty to receive the link for webinar, although I send you my email.
Okay, we'll talk later, okay?
Okay.
Gerald Musa. Perhaps he stepped away. I know Dung is there. Dung Goga.
Hello?
I know you're there.
Yeah. Good evening, everyone. I'm Guga, a resident in neurosurgery in Nigeria. I'm glad to be here.
Okay, welcome.
Okay, wonderful.
Thank you.
Welcome.
Thank you.
Okay, Mansour, thanks for taking time to put this together, and welcome. It's all yours.
Okay, thank you. Well, good evening, everybody. Thank you for joining in, and thank you and welcome to everybody on YouTube and all the other people watching elsewhere, and etc. I'm sorry I'm looking a bit tired and disheveled. I've spent some time in A&E recently with family and relatives, and it's been really inspiring to see, despite 1/4 of the world on lockdown and so many difficulties, the staff, I just want to give a big shout out to them, that they've been absolutely brilliant in looking after my relative, and despite being in the medical profession myself, to see what's going on in accident emergency and how kind they were, it was just wonderful. And he's been admitted, and they're keeping a very close eye on him, and we'll see. And it's related to this COVID crisis. So welcome, everybody. I'm a neurosurgeon from the southeast of England. I work in Brighton, but I work in several hospitals, and also practicing privileges in London and all that kind of stuff. My areas of interest, my specialty training was in vascular, skull-based, and pediatrics, and I serendipitously got into complex CSF disorders when I spent a few years as a consultant in Birmingham, which I absolutely loved, and hence my interest in Chiari, malformation, syringomyelia, and complex CSF disorders. The subject of today's talk is really about, there's going to be in two parts, and I welcome any questions. And we're going to have some case discussions, and I'm going to put some questions there. And there's a lot of nuances in this subject. That's why I like it. One of many reasons, not just because it's very common, because it has so many facets to it. There's a lot of nuances, and there's a lot of simple points, which in my view and others have just been misinterpreted and are just not dealt with appropriately. So we're going to hopefully clarify some things and simplify some things, which are unbelievably simple for considering this is neurosurgery. And so please do join in and ask questions. The second part of this presentation, on another day, I'm going to focus on the operative techniques, because there's a lot to cover there. There's a lot of variations, and I hope Professor Atul Goel will honor us and join us for that one, who was our guest in Birmingham 2 years ago for the Chiari meeting. So welcome again, let's crack on. this is a few slides I've got from Graham Flint, who really inspired me to get involved in this subject. And Graham is a retired neurosurgeon, Queen Elizabeth Hospital in Birmingham, with huge experience in many things, in spine disorders, a massive experience in Chiari syringomyelia, colloid cyst. He's done dozens and dozens of them. But it was his trainer and senior, Bernard Williams, who was a legend really, and pioneered many things, and the one who proposed the Williams theory for syringomyelia, that that had a lot to do with Graham getting into this. And then Graham and he asked me to sort of get involved with the CSF disorders, and of course, nationally, internationally, patients would come there for these operations, and because a lot of the redo and complex disorders would come to Graham from around the UK. So Bernard Williams is really a mutual source of inspiration, and this is his gravesite in Birmingham, where we visited, and this is going back over 2 years now, where for the Chiari meeting we went to visit him and pay our respects and prayers. And this is Graham with Marion, his wife there, and a number of delegates from China who honored us by coming, plus lots of other people from around the world. But this was just a small group that we went visiting. This group from China will come back to, absolutely wonderful people, and they're really the group and the senior responsible for pioneering a new technique in the operation and minimally invasive technique for dealing with Chiari syringomyelia. Here's Paolo Bolognesi, Girish there from Birmingham, Graham, many other colleagues, myself in the same meeting. And there were, of course, about, I think, altogether, well over 100 of us there. Now, what is Chiari-1 malformation? This is very important. And Rafi, please feel free to shoot any urgent questions so I can address it on each slide. But the definition has been vague, and this has been one of the problems. But in 1891, it was his first description, really, where Hans Chiari, who was a pathologist, originally trained in, I think, in Vienna, who was working in Prague at the time, and he was very big on anatomical dissections and postmortems. And he described, I think the first case was really a 17-year-old who had passed away as a consequence of an infection totally unrelated. I'm not sure if it was cholera or some that effect, but he described the piston-like cerebellar tonsillar descent, which had impacted past the foramen magnum, and a series of other cases were then described. So that was his first description. And then Arnold described a case, and the students of Arnold a few years later called this Arnold-Chiari malformation, attributed then to both. And its definition since that time has been vague, I'm sorry to say. Some people say it's extensive 2 millimeter beyond the foramen magnum. Most of the world tends to go, as far as I'm concerned, when we discuss it in meetings, that if it's a protrusion of 5 millimeters or more, cerebellar tonsillar descent beyond the boundary of the foramen magnum, then we say there's a Chiari-1 malformation. It is as simple as that. It is so vague, sadly. But what we should do is pay attention to the characteristics of this descent, of the symmetry or asymmetry of the tonsillar descents, with degree of compaction, or how it's impacted, and whether they're pointed and deformity, which I'm going to come back to. This is very important, particularly for trainees. Very important to talk about its prevalence. It's a staggering 1% of the population. Some say more, some say a bit less, and up to 3% in children. So it's not a disease, it's an anatomical finding, essentially, if you want to put it that way. But its prevalence is huge. And therefore, we need to important to define whether their patients are symptomatic and the cause for the referral and the detection or imaging, or whether this is incidental. And there's a condition which many of you may have heard of, and it's called vomit. And we're going to talk a little bit about this now, because this is the most common mode of the presentation of the Chiari-1 malformation. And this goes back to a paper. Can everyone see this?
Yeah, yes. We can.
Yeah,
Yes.
okay. So
Yes.
this is
Yes.
one of these wonderful essays that Richard Hayward wrote, and articles. And Richard Hayward is a retired neurosurgeon from Great Ormond Street. And he described victims of modern imaging technology. And here's a tale of two sets of parents from two different children who had incidentally detected something on a scan, one arachnoid cyst and something else incidentally on a spine. And they waited a while to see him and were very anxious and concerned. And he described this scenario and the patients and the parents as literally victims of modern imaging technology. And he proposed that this is a price that you pay for advance in technology. And indeed, we're seeing a lot of it. Now, what does it really mean for us? There's a lot of anxiety and fear sometimes when say incidentally to diagnosis, and I'm talking about diagnosis such as the following. Arachnoid cysts occurs in 0.5% of the population. So if you have an MRI scan, 1 in 200 will have one of these. And meningioma, the most common tumor within the head, about 1 in 200 will have a small meningioma or a large one, but usually vast majority small. Chiari malformation, type 1, and almost 1%. Cavernous hemangioma, 0.3%. Aneurysms, 1 to 2%. AVMs, 0.1%. And the list goes on and on. So about 6 to 7% of all brain MRIs, you will find some diagnosis of something, which is quite staggering. And therefore, I mean, there's an example, arachnoid cyst, 1 in 200. This is another one. This is a large one, which was symptomatic. And all these cases I'm going to show you operations cases done by myself or within our team. And this was dealt with and endoscopically and very nicely, a good outcome, thank God. But this is one. For every one of those, I might see 20 or 30 of incidentally detected asymptomatic, don't need anything doing arachnoid cyst. Here's a 40-year-old, an academic with this arachnoid cyst, which caused some worry. And needed reassurance that nothing should be done, nothing needs to be done, and almost certainly in the course of his lifetime, nothing is going to be required at all. Here's a meningioma occurring 1 in 200. Here's a Chiari, which is incidental. And there's different types of Chiari. Look at this one on the left, and then look at the one on the right. Surely you could see that one might be more symptomatic than the other because of the degree of impaction and the beaking, the pointing, and the CSF space obliteration. And this was a scan with someone presenting with some facial numbness, swallowing difficulties. So they think, well, is this related to this? You can imagine anxiety. I would say highly unlikely this was the responsible cause, but they need to be seen and reviewed and anxiety alleviated and reassurance given, and appropriate investigation for what other causes that maybe need to be identified. Here's another one. Look at this. This is not really a syrinx. This is a little incidental finding of probably a dilated central canal that doesn't need anything doing. Here's something a bit more than a dilated central canal. This didn't lead to any intervention at all. And these are purely incidentally detected. Here's a cavernous hemangioma. And so basically this is very real, and the world is seeing much, much, much more of these. And this is a real problem that needs to be dealt with. And some principles to share with everybody is that don't start looking for things that are not worth finding. So be careful who you ask for a scan for, and when you do find incidental things, then you need to inform, educate, empower the patient to help themselves. And they need to be counseled appropriately with tact and wisdom. So for example, if you detect an aneurysm, of course, aneurysms are a risk of hemorrhage, but the vast majority are not going to bleed. And how you monitor that aneurysm and that patient with the aneurysm is very important, and many ingredients involved. Cavernous hemangioma, far less risky, and almost certainly does not require any surveillance. And a Chiari malformation just doesn't. So there's different regimes for different findings, but all patients need to be counseled appropriately so they're aware of what's going on. And here's the gem that nurse specialists are really required and very, very helpful in such roles, rather than taking up the time of perhaps surgeons who may be better off dealing with other issues. And if they need it, then that's fine. But the counseling and the information provision and the review can be done by others besides the surgeon. And protocols are very helpful in this field. And we should be aware of conveyor belted medicine and faceless medicine, where just letters are just simply sent, or a protocol is arrived at and patients are informed and thinking that's good enough. So we have to be flexible and be able to attend to the needs of all patients. Now, those are really just to deal with the asymptomatic concerns. So once again, the conclusion is the vast majority of the Chiari-1 malformations that we certainly see in the industrialized countries are incidental and asymptomatic, and that's a fact. Now, what do we mean in this presentation, hopefully, with in terms of clarification about what's a Chiari-1 malformation? We're referring to a small posterior fossa with herniation of hindbrain through the foramen magnum. That's essentially what we're referring to. Its dimensions, we say 5 millimeters or more. but this is going to be classified with some articles coming out hopefully later this year by a group we're putting together. And we should look at also the deformity in terms of, whether there's beaking and impaction and asymmetry of the tonsils coming through a foramen magnum. We should look at the CSF space and obliteration of the CSF spaces. And I think these are three key ingredients to be able to define the severity of the Chiari malformation. Volume of posterior fossa, so many ways to measure this. We don't tend to measure it, but dimensions are useful when trying to analyze the causes and also in studies to sort of define what's the cause of Chiari malformation. So the distance between the bason and the piston is key, as well as the width and the association of this condition with atlantoaxial assimilation, clipal file, and scoliosis and other things goes without saying, which we're going to cover. Now, as I said, this was first described by Hans Chiari, and there are different causes of the finding. As we already said, what he described was essentially a 17-year-old with almost certainly hydrocephalus who died of an unrelated reason, and it was an autopsy finding and with a significant Chiari malformation. So one Chiari one is not the same as another. It depends what the cause is. And what are the causes? Well, we can classify it into either overcrowding, in other words, underdevelopment of the bony structures in the posterior fossa, and a disproportion between the neural tissue and the bony compartment. We can classify the cause from hemodynamic with increased ICP. If the intracranial pressure is high or rises, you will get development of herniation to some extent of the neural structures through the foramen magnum. And this could be chronic and, God forbid, acute, which is obviously very dangerous. Excess tissue contents, a tumor or a cyst, we're going to come across these examples. And of course, a low intrathecal pressure. So following insertion of a lumbar peritoneal shunt or a CSF leak or spontaneous intracranial hypotension, this can cause a Chiari appearance. And would you believe it? These examples, I'm going to show some examples of what reasons for referral of Chiari certainly to my practice. So it's not just detection, it's detection of the cause. And it goes without saying, sounds simple, but they're very easy to confuse. Sometimes they can be easy to confuse, and people attend paying attention to the Chiari and saying, let's intervene for that and do a bony decompression, but the problem is actually something else. Now, the embryology of the skull, some useful articles for you. It's well and truly defined now that there is a cause and there's an association between the small posterior fossa and a Chiari 1 presentation. And this would be the cause for, certainly from my view, the vast majority of Chiari 1 malformations that we see. So they're not from other causes or instability or raised ICP and so on. And on average, Nishikawa in 1997, they showed that the Chiari group had a smaller posterior fossa with the dimensions I've written there, and a significant difference in posterior fossa brain volume to posterior fossa cranial volume with the figures described. And the similar things have been described by others. And of course, in the periaxial, a nice article with looking at the periaxial mesoderm insufficiency, which was vitamin A induced in hamsters. You could induce a Chiari, and which was described quite nicely in this article. And so embryologically, we can see that there would be a cause behind having a deficient or a tighter or a smaller posterior fossa compartment from embryological development, which could cause this. Interestingly, which we're going to come on to also later, is that this is seen in other animals, and particularly dogs. And this is very interesting. We'll come on to that. So some examples. We looked at colloid cyst last presentation. So here's a colloid cyst, and there's a nice good going Chiari, but you don't want to do a Chiari decompression for this. You treat the cause in the hydrocephalus and the cyst. This is another tumor that was referred to myself some time ago, and this was a medalloblastoma. This is a 43-year-old lady who was referred, believe it or not, as a Chiari, because on the MRI scan for a spine, they just caught the descent of the tonsils, and then on a subsequent scan, they found this tumor. And this is some of the pictures of the operation, and the meningium was out, and she's doing well. Here's another example, a 31-year-old bedbound for 4 weeks, poor mobility. This was some time ago, some years ago. saw this patient, and she was initially treated for benign intracranial hypertension, or should we say idiopathic intracranial hypertension, because there's not much benign about it. And she had a lumbar peritoneal shunt inserted some 10 years prior to this presentation. And after weight loss following gastric procedure, she had done well, but she started to deteriorate with right-sided motor function deficit and far worse than being upright. And eventually she became immobile. And this was her scan. And I can tell you she didn't have a Chiari-1 malformation and this small syrinx on her previous scans when she had IIH. Or rather, it was much more mild. So the cause of this was the lumbar peritoneal shunt, which was an old shunt without a valve on it and with very low resistance. The first thing we did was tie that off. And obviously she didn't improve, but eventually had to do posterior fossa decompression, sitting position on this young lady. But this was another cause and a well-described cause, a Chiari, which is induced by a lumbar peritoneal shunt. Here's another example. Now, this is a Chiari, but the cause is the arachnoid cyst and the consequential hydrocephalus. So we had to treat the cause, the underlying cause in the patient, not the scan. And here's another example. This is a history, a nice story of someone presenting with headache, which was sudden onset. And this is not an uncommon scenario. You'll probably see one or two, but at least a couple a year. No prior significant headaches, sudden onset. I think this was while driving, continuous and episodically worsening. Multiple admissions, sadly gave up work for a while. And the headaches were worsened by coughing and sneezing. But the underlying cause was not a Chiari-1 as a presentation. We did some MRI scans and images, and this was his MRI. Are there any comments from anybody what the cause could be with a sudden onset of headache and headache, which would be worse on sitting up and being upright? If there's anyone wants to make any comments, welcome.
Not yet, but obviously that is going to be, we'll see if any of the guys come up with anything. So you're basically saying somebody with a protrusion of the cerebellum, but the headaches are worse when they're sitting upright or standing upright. Yeah. When they lay down, they improve.
Yes, but of course in this case, also after a while when he's lying down after 2 or 3 hours, trying to sleep at night, he also gets headaches. So, but the initial presentation was a classic sudden onset and clearly worse when he stood up. And he was
any sudden back pain, or was it just a headache?
Headache, that's a good question. And as you're alluding to it, the problem was what we suspected was spontaneous intracranial hypotension. So this was, we thought that he's got a spontaneous CSF leak, and he did have that, and he went on to have blood patch. So the cause of the Chiari is not small posterior fossa. The cause of the Chiari, or the worsening of the symptoms, should I say, was intracranial hypotension from the spontaneous CSF leak. And this is not uncommon. Every couple of years, every year we see 2 a year or something like that. And it's well known. And it's a diagnosis that's been much more easily detected in the last few years with the advent of MRI and showing neuron enhancement and so on. So some review of the underlying causes, but let's talk more about the Chiari-1 and especially its association with syringomyelia. So in systole, the venous capacitance absorbs pulsation. And if you can assume there's about a 1 mil of CSF moves from cranium to spine and back in diastole. In Chiari, the tonsils move instead. This is one theory, and certainly it's a theory that I tend to accept because it's what we see during operation and what you see during imaging, dynamic imaging. And in partially entrapped CSF space, there's reduced compliance, and therefore the tonsils act like a piston to produce sort of an increase in intrathecal pressure and an increase in pulse pressure. Its prevalence, once again, is noted to be very variable, but I think a 1% prevalence is very realistic. And I put some figures there with different papers suggesting different things. And its prevalence, interestingly, is higher in children. Please note this because this is well known now. So why is it, you have to think to yourself, it's higher in children but lower in adults? Well, because the cranium grows, so it can resolve. So if you've got a mismatch between neural content and cranial capacity, it's conceivable that as the child is growing into an adult, that this can resolve. And indeed they do. We have come across cases where children have been followed up into adulthood and you see that the Chiari has resolved. And that's very interesting and certainly a well-recognized fact. So the tonsils can move up, and there's several reports of resolution of Chiari syringomyelia, and I put 2 of them there, and etc. Thought to be slightly increased prevalence in females, but it's not related to obesity. And we know that now there is no merit in surveillance. If new symptoms develop, that's a different matter. Symptomatic prevalence is very interesting because this comes down to textbook description of its prevalence and its incidence, and then its association with syringomyelia, which was supposed to be 60%. But of course, we know that's not true. It cannot be that there's 60% association with syrinx, because we now know the vast majority of these are asymptomatic and not causing any problems and just incidentally detected. And they certainly don't have a syrinx, almost all of them. But the lower tonsillar position and symptoms is associated with syrinx. These are some of the symptom prevalences in the pediatric population, which I'm going to jump ahead because this talk not so much about pediatrics, but I wanted to show you this. This is important. In adult population, the cough headaches, the tussive headaches are the classic presentation. And one tip I can give is that the headache tends to be the vast majority occipital, at the back of the head. And it tends to be classically with a little delay. Now, this is a point of controversy. Some people will say that's not true. And I can name those conferences when we all meet as every year. But the vast majority of us really do believe from the experience, and certainly Graham would say this, who taught me a lot of this in Birmingham, that there is classically a short delay, a 1 second gap perhaps. So they will cough and then they get the headache at the back of the head. So this is the most common symptom by far. Of course, neck pain can be there, facial numbness can be there depending on the degree of impaction. Tinnitus can happen with traction on the eighth nerve, dysphagia, regurgitation, stridor, sensory motor symptoms, ataxia, of course, and diplopia. It just depends on the degree of compression and severity of the Chiari. Something I wanted to mention to you that it is known to be worsened by trauma, by severe trauma. So if you've got a severe head injury with raised ICP, that can certainly worsen the presentation and make a Chiari much more dangerous. And the only 2 scenarios where sudden deterioration, to the best of my knowledge and the literature, has occurred is 2. One is with onset of meningitis, bacterial meningitis, and having a lumbar puncture, or bacterial meningitis, and of course raised ICP and a lumbar puncture. And the other one is following severe trauma, the major head injury and brain swelling. Other than that, there are no reported cases of sudden death or acute deterioration in adults. So this is something that I think is useful for everyone to be aware of and remember, because there's even newspaper articles and false fake news, if you like, that you can suddenly deteriorate with this. Or there was one newspaper article some years ago in the UK where someone was told, doctors told me if I laugh, I could die. Yes, it's nonsense. That's not the case.
Also, can I ask you on symptom point of view? So, as you said, this can be an incidental finding, etc. What do you find as a symptom is the most, not sensitive, but the most specific, if you like? So the thing that you depend on, which you'll say, do you know what? Okay, this is relevant in your case.
Yeah, cough, headache. Strain-related headache. So when they cough, they get a headache. When they bend down to get something out of a cupboard, doing vacuuming, straining on the toilet, any cause for strain, putting up ICP. But
the location of the headache matters to you?
Yes, it does. Yeah, it does. And because it occipital, back of the head.
Okay.
And so the migrainous generalized headaches, no, I'm not saying it can't happen. It can, but the classic one, the one that if they have this symptom, it's very much associated with the severity of a Chiari, and can be relieved easily, most commonly with an operation. That's not to say they all deserve an operation, but it's something that's going to say, well, that's an option. If it's really upsetting you, these headaches, and you can't bear with it, then very likely to respond to surgery, which we're going to come on to the next time. But yeah, it's the cough, headache, and strain-related headaches. Now, some little comment about a Chiari 1.5. This has been put about in the literature, and it's not a Chiari 1 or a 2. They're saying, some people are defining this, that it exists and it's a way of classification. And again, it's anatomical. All it refers to, descent of the cerebellar tonsils, a significant portion, whether you call it 5, 7, or 10 millimeters, whatever dimension, past the foramen magnum, but also descent of part of the brainstem, at least past the foramen magnum, like in this case. For me, it doesn't have any great merit. You can just say, yeah, it's like a really significant Chiari 1. And does it need to be decompressed? Well, it just depends on the symptoms. And you have to, again, do the whole screening and look at, is there hydrocephalus? Is there a tethered cord? Is there a syrinx? And what are the patient's symptoms? So look at these things on imaging, and particularly beforehand, look at the history and examination findings. But it is put out there as another classification, 1.5. Now, Chiari with syringomyelia. I'm not going to talk huge amounts about syringomyelia, but I'm going to touch on this to some extent because it is very much related. And it's a subject that's well worth a discussion. And maybe if I could invite one day Graham to come and join with this presentation, that would be wonderful. And these slides are from Graham, who shared this with me some time ago, from the Anne Conroy Trust, which is a wonderful charity that deals with informing patients about Chiari and syringomyelia and providing good, solid use of information, useful information for them to be empowered and help themselves, and as a good guide towards treatment and management. So Anne Conroy Trust, a big shout out to them. Now, there were many theories that were put about causation of syringomyelia, especially associated with Chiari malformation. And as a student, I used to like reading about these theories and memorizing them and learning about them. As every one of them has been sort of come and gone and criticized that it doesn't always explain, doesn't quite fit with the whole scenario, I've lost a great deal of interest, to be frank with you, regarding that. But let's review them because they are relevant. Gardner and Angel theory, proposed in 1959, so it's a Chiari 1 malformation with associated syringomyelia, underlying hydrocephalus, and it was proposed that the occlusion of the foramen magendi, which is in the midline, and Luschka, which are laterally. So remember, magendi midline, Luschka laterally. The CSF is forced in the central canal by the obex and driven by choric plexus pulsations. Doesn't quite fit with, there are many arguments against this, but we're not going to go into that. But it was very valid for a long time. Bernard's theory, some good presentations about this on YouTube. Please do look this up. And he found a good dissociation between ventricular EVD pressures and CSF, and ones that were measured from the spine. And essentially, he thought that the hydrocephalus was not the underlying cause. The important factor was obstruction to the CSF flow at the craniovertebral junction. And this was identified following detection of craniospinal pressure dissociation. So when they measured the pressure waveform in the head and the spine, there was a delay and there was a dissociation. And therefore, the valvular effect of the tonsillar herniation was thought to be responsible for this, and also the importance of venous pressure waves. But of course, this has been criticized later on. But Bernard was a giant in this field and a remarkable man. Ball and Dyer, 1972, they thought it was movement of intrathecal water-soluble contrast media via detection via water-soluble contrast media. And they thought it was via a transparent chymal flow rather than via the obex in the fourth ventricle. And they thought so the root behind all of this, the causation of syringomyelia, was along the perivascular spaces. Again, there's many arguments against this. And more recently, the Oldfield theory, Heiss and Oldfield in 1999, where they thought there's the piston-like action of the tonsils during systole. And this is very attractive for me. It really does fit that somehow the piston effect would be the causation or a big contribution to driving CSF into the cord. Of course, other theories have been put. I loved to have a session with Professor Coel, who's a giant in neurosurgery, really, and his paper and his description regarding what he's termed as the nature's airbag, which could be the case, but I believe, and certainly others do, that the instability at C1, C2 is for a group, a subset of patients that can present with a chiari malformation, not the vast majority. And we may be wrong, maybe he's right, but we haven't seen the evidence for that, but it'd be lovely to talk about that. There's also other theories, but like the volume change theory, that the spinal canal volume is greater in flexion than in extension, and this was put in the paper, and the movement of flexion extension with a slight predisposition can cause syrinx formation. Personally thinking, I think there's no one cause. Even when you don't find any other underlying cause on imaging and during examination, surely it's not one cause for everybody who has got a chiari and a syringome and a syrinx. But the important thing is treat the underlying pathology and do what works and do no harm. Now, I've written there Cavalier King Charles Spaniel and Griffin Bruxellois, and there's some other comments afterwards. Is anyone familiar why I put these two names there at the top? If there's any comments from anybody.
Yeah.
Any comments? Anyone want to say anything? What do they know? What's the association between Cavalier King Charles Spaniel and Griffin Bruxellois and this subject? Well, so in the Syringomyelia Chiari meeting 2018, it was one of the excellent lectures was by Claire Rusbridge, who's a vet, and she's really world authority on this subject. And the two names at the top are two breed of dogs, in which Chiari malformation with Syringomyelia is well recognized. And you can go and look up numerous videos about dogs presenting with Syringomyelia and Chiari and how they present and how they excessively scratch themselves and how they are unhappy in the pain and discomfort they're in. And it happens, and it's a well-recognized thing. And these are some pictures of the one on the left is Cavalier King Charles Spaniel breed, and Griffin Bruxellois is on the right. And of course, it happens in other dogs such as Chihuahua, etc. And it's to do with the breed and what we've done to sort of breed these particular size shapes as skull dogs. Here you go, some pictures via the internet about how one has got a Chiari Syringomyelia and one doesn't. And so it's interesting how the same pathology can happen within another species for same reasons, perhaps, with a mismatch between the size of the skull and the neural contents. And the symptoms that can happen in dogs is pain. And they won't tell you I'm in pain, but they look uncomfortable, they look unhappy, they will moan, they will scratch themselves and even go for the back of the head, their posture, their sleeping position, neck scratching, behavioral changes, ataxia. This is an interesting paper from 2012 where they hypothesized the volume reduction of the jugular foramen in Cavalier King Charles Spaniels with Syringomyelia. This was spotted and seen on imaging, and a hypothesis that was put that the cerebral venous drainage capacity determines whether or not the Chiari patient would develop Syringomyelia. So this was very interesting, I thought. And the hypothesis is sort of summarized there. So it's interesting that this is even more reason to think there is not one cause for everybody. It could be mismatch, it could be a venous thing, it's a pulse pressure thing, there's and so on and so forth. So it's not a disease, it's an anatomical finding essentially to begin with, and then possibly further pathological findings like Syringomyelia, etc. And really the treatment for Syringomyelia, the principles there I've just put there, which you're not going to talk about as the main subject, is to create, if you treat the underlying cause, and if that doesn't make it go away, then you create a conduit for normal CSF flow, or you drain, the next stage, drain the syrinx directly, or you can try lowering the overall CSF pressure, or conservative management if patient is in agreement and on balance is the right thing to do. Something I'm going to touch upon, because I think it's very important, is the concept of syrinx and no syrinx. And for neurosurgeons who are in this field, I'm sure they light up because this is a big issue. Once again, if you do MRI scans of the spine, particularly cervical thoracic spine, you will find lots and lots of so-called syrinxes or dilated central canal or a spindle. And the radiologist will say, seek help from a neurosurgeon. This is another source for vomit, victims of modern imaging technology. But it needs to be addressed. So Pettit et al. In his paper, they found that around 1.5% of all MRIs show what they would call as a dilated central canal as a non-serine structure. And that definition would be that the cavity that is seen with the white sort of the fluid-filled CSF space is 0.4 millimeters or less in diameter. And of course, it's not associated with any horstrations and certainly no contrast enhancement with any pathological finding. And these are extremely common. And I've shown you some examples there with help of previous. This is a slide from which Graham had shared with me before. You can define one on the left as just simply spindle, persistent central canal, the second from the left, a dilated central canal, and a fully formed syrinx is what you've got on the right. And sometimes you can't just say, look at a scan and go, yeah, that's a dilated central canal. If you're suspicious, then you need to repeat the scan and do a surveillance imaging, and then do one with contrast enhancement. So, but it is a real issue where the vast majority we know are just dilated central canal and just a benign finding. Nothing needs to be done.
Would you depend on the size for that also, or what sort of imaging findings? Which
No, it's a good question. I think a criteria that's being given is anything less than 0.4 millimeters. Anything less than 4 millimeters in diameter is a good safety margin, but it can't be just taken categorically across the board. The length of abnormality. So if you've got a long length of a sliver, a very slight dilated cavity, that's almost certainly going to be a persistent central canal. But if you've got a ballooned cavity, particularly, sorry, have we got a bleeder?
yeah, we do. John's dealing with it.
Okay, sorry. So if you have a big focal dilatation, that's much more likely to be a syrinx. If you've got an irregular dilatation, then really that's alarming. If you've got horstrations where you've got a dilatation and then a membrane, another dilatation, that's very alarming. And of course, if in doubt, you do a contrast enhanced scan. And then if that doesn't show any abnormality, that's very reassuring. Then do one surveillance imaging. But there's not one set formula, but a good one is to look at the width, the diameter, the length of the dilatation, any irregularity, and certainly any enhancement. But once again, the vast majority of these are just not syrinx at all for the reasons described. I hope that helps anyway. Here's a picture of a nice Chiari and a syrinx. I mean, there's no doubt about that, the size of that cavity. And maybe I should wait for et al. For the next time to join, but this is one of the other groups and hypotheses that's been put, and quite an important article where et al. Had proposed, his group, long time really, that not just in 2015, that Atlanta axial instability is the cause of Chiari malformation. Outcome of 65 patients treated by Atlanta axial fixation, he actually devised and proposed a new fixation technique really for C1C2 a long time ago for this. And essentially, they were saying that the surgical result described lead us to speculate that Chiari malformation can be nature's protective mechanism that assists in reducing the effect of instability and cord compression by the odontoid process. And he said that we speculate Chiari malformation may have an airbag type of influence that prevented pinching of vital neurostructures between the bones. Now, it's a kind of belief thing with this. I personally, and I don't mean in disrespect, I don't believe this as the cause, but I know that his results are very good for this. And if you do a fixation where there's clear instability, it can help the situation and regress. Great, I think that's fantastic. Whether you call it nature's airbag, I mean, I don't know why nature would move cerebellar tonsil somehow to round the upper cord to act as an airbag. I mean, I'm not sure what protection that will offer. Maybe to reduce movement by tension and increasing headache. But let's say that does happen, fine, because odd things happen with organs moving. Look at the abdominal policeman, the greater omentum. We know that will move to seal a perforation. Maybe there is such a thing as this proposal, and that's fine. But what's for certain is that the vast majority of cases of Chiari we see, this doesn't apply because there is no instability. So I think there's a subset of patients, and which may be much more common, particularly in India, in vast patient population, who have got instability, who have got really a primary craniocervical craniovertebral junction anomaly and problem that this applies to. But the vast majority of problems we see with Chiari are not related to this. And this is from Atol's article. And you can see, look, I mean, you've got cranial settling. Sorry, I don't have a pointer here, but you can see the dents in the cranium in one of these scans. So the kind of anomalies that you see in this particular article with the patients treated are not the same as the Chiaris that we see in everyday practice. This is a different, this is a subset of patients with craniovertebral anomalies and potentially connective tissue disorders and so on and so forth. And there's a whole range of problems here. There's basilar invagination, there's major deformities here. So I'm going to skip ahead, and I'm going to, just to make the point, I've gone and just looked at, for some years, I used to do x-rays for instability on all Chiari-1 patients who presented. Not one showed any instability. So I'm just showing some examples. So this is one. This is a flexion extension, no movement. This is another one, no movement. I'm sorry, I could just show you this all day. This is another one. It's supposed to be Ehlers-Danlos variant, and we did flexion extension MRI, no significant change. I'm going to come back to this pathology in a while. And here's an 18-year-old with this scan and significant Chiari with impaction and no instability. Here's a 22-year-old with significant Chiari and symptoms, and again, no instability. Here's another one with a DNET tumor in the head as well, and x-rays and no instability. Here's one with severe cough headaches awaiting surgery, so significant Chiari, and another one and no instability. I mean, the list goes on and on. So we haven't seen this, and know the vast majority of colleagues that I work with in this part of the world. But I think we may be getting two different pathologies, two different things mixed up here, and it's unbelievable how this can happen for intelligent colleagues. So I think it's good.
Well, I think also, as you say, there may well be sort of a different subset of population, and that is, we do see that clearly with different patients, different pathologies in different regions. Yes. But I think, I mean, yeah, just moving away from dogma, I mean, it's just something to be aware of anyway. Because, and as you know, when we sit in the MDT, we often do the flexion extensions, do a CT scan. We look for any abnormality between the C1 and C2 joints, so we're aware of it. And I think that, in my opinion, is something important as well.
Oh, sure, absolutely. I think it's well said. Look, you know yourself, recently we even one case recently, we're going to do a joint case, I think, on one with instability. But it's a clear anomaly with a craniocervical junction and instability and a congenital spine problem. And he has a Chiari and a syringomyelia, which is significant. But that's different. That's not the craniocerebral disproportion with a small posterior fossa and nothing else going on. So I think it's useful to mention this because, you know, we can't be dogmatic about it, as you say, to say it's C1, C2 fixation for these. It isn't. Clearly it isn't. Otherwise, the rest of the world would be doing this. There's some more scans with various symptoms. And here's a 22-year-old with minimal symptoms offered for conservative management, despite having the syrinx there. So just because you see a syrinx the old school way of saying you got a sinus to the Chiari surgery. No, the patient's perfectly entitled to say no. I'll just continue with surveillance for this. But at the age of 22, I did advise against it. I said I would recommend intervention, and she did eventually come back and have surgery for that. This is a 32-year-old with incidentally detected Chiari. Incidentally, look at the degree of impaction and the descent. It looks significant, and you can clearly see the posterior fossa is kind of small for this structure, and no other underlying thing. This is a case of cluster headaches, as was defined by a neurologist, as well as generalized headaches related to Chiari, with some occipital headaches, which were cough headaches. But the main issue you can see here, as you can see, Rafid, and I'm sure others can see, is the hydrocephalus. You've got a depression in the floor of the third ventricle and a bowing out of the lamina terminalis. And this is, we shouldn't be going ahead doing a Chiari here. You should be treating and paying attention to the hydrocephalus, if anything, first. So if you need, do ICP monitoring if in doubt, but you treat the underlying cause. So with all Chiaris, we have to think, is there underlying cause? And image the head and the entire spine if they're symptomatic. And in the head, you're looking for hydrocephalus, so any lump, bump, cyst, any cause for raised pressure. And the spine, you're looking for syrinx or a tethered cord and such anomaly. And we're going to come back to that by what investigations. Now, something which is very topical and for experts in this field to know about is a controversial diagnosis where this paper is referring to it, and so is this one by Henderson in the United States, and these are colleagues that we get together with in meetings, because there is a subset of patients who are thought to have hypermobility spectrum disorder. Now, this is different to just Ehlers-Danlos. I hope everyone can hear me. Ehlers-Danlos, the prevalence about, let's say, 1 in 5,000 population, 13 different types more recently described. There's some suggestions gone up to 20 now. When I was a medical student, there was only 7. And this is, they can present with a whole range of problems, not just, skin elasticity and joint problems and musculoskeletal issues, but, uterine rupture, vascular disorders, aneurysms, and so on. And it can be a very disabling problem. But we know now increasingly from various patient groups and reports that there is a group of patients who have not Ehlers-Danlos, but have some degree of hypermobility, and particularly following an accident or an event, can have a range of symptoms which are difficult to pin down, and some would say would require, certainly for neck pain and Chiari type symptoms, a craniocervical fixation. Extremely controversial. I don't know of any neurosurgeon in the United Kingdom who offers this surgery. The surgery is done for lots of other conditions, and people have raised money through crowdfunding and things to go to Europe to have this surgery done in Barcelona or the United States. And I have much sympathy with patients because we don't know the real cause to this day. What's the cause behind this? But it is an increasingly recognized problem which needs to be researched and identified more. And essentially, the premise is that there is a hypermobility spectrum disorder where it's not just 1 in 5,000 population, it's much more likely to be perhaps 1% of the population who have hypermobility and a predisposition to such symptoms. I'm not talking about the 10% of the population who have hypermobility, but this is related to patients who can have, by definition, as from Smith, who's a radiologist in London, he does upright MRI for such patients, and he's put his criteria as what is detected as the cerebellar tonsils do not descend like they do in the midline, but this is more lateral depressions and protrusions of the cerebellar tonsils in this group of patients who also have some element of cranial cervical laxity and instability as defined by his dimensions, which I've put here for you. It's very controversial once again, because it creates a big headache. You don't see a significant Chiari. There's no impaction. There is no obliteration of CSF space. So you wouldn't look at the scan and more importantly, look at the patient and say, I'm going to offer an operation to you, which is potentially, which has potential complications. And I'm not sure if it's ever going to help you with your symptoms. But a certain number of these patients have gone and had craniocervical fixation without any studies, effective studies yet being done at the moment, and have benefited, although some haven't benefited and some have ended up much worse, sadly. But this is an area of controversy, and I'm just putting it there for sharing experience and to say this is an area where a lot more work needs to be done, and things are just not clear. So common questions, this is very important, and coming to the end of this particular presentation, is that common questions come up with Chiari. One is there any merit in surveillance? The answer is no. Generally, no. So if you've got someone with incidentally detected Chiari malformation, protrusion of cerebral tonsils 5 millimeters or more, and it's incidentally detected patient is well, no need to do any surveillance. Absolutely not. Now, if you've got someone who's very anxious, particularly if it's a significant protrusion with a degree of impaction and etc., then I would say it's good to have surveillance clinically to let them know what to look out for in case anything develops, particularly if they're young. And if any symptoms develop, then do a scan. If you do a scan for simple reassurance because they're very anxious and you do one in 2 years, make sure they're not getting a syrinx or something like that, that's not unreasonable. So we have to be tactful and wise. But for someone who's asymptomatic and it's mild, absolutely not. Is there any sudden deterioration seen? Once again, the answer is no. So if patients are asking us, doctor, is there any chance that I could suddenly deteriorate, God forbid, drop dead, become paralyzed, etc.? The answer is no. And if you think about it, it will be no. Because if you have almost 1% of humanity who have this kind of finding, and let's say 1/10 of that proportion is much more severe, and so far in modern medicine and history, there's been no description of sudden deterioration and coning and neurological damage, which surely would have been done. That's proof by itself. And that principle would apply to pregnancy. So we know that ladies who are pregnant can have a Chiari, but there's not even one case of sudden deterioration or death or rapid or any major harm following pregnancy or during pregnancy. Just you can get symptoms getting a bit worse, but no massive or sudden deterioration. The only time it can happen, in theory, although, and I know I've heard of 2 legal cases worldwide, is that if you have a significant Chiari and you've had a spinal anesthetic and had a leak and a CSF leak, then you can have that. So it's best to avoid a spinal in a patient who's got a significant Chiari malformation with impaction. I think that's just good, sensible advice. But can they have normal pregnancy, normal delivery? Yeah. Do they need a cesarean? No. Incidentally, majority of patients and clinicians we give this advice to sadly still end up having, from my experience, or a decent proportion end up having a cesarean because it's perhaps a safer thing to do or whatever. But there is certainly no risk in pregnancy from the literature and from what we know. Imaging. Do you need any special imaging like flow studies? Now they're becoming more common. The problem is that flow studies take time to do. And I love the more advanced CSF studies, but they take extra time. And you have to think to yourself, is this worth it? Is it providing any more information than I really need? And my answer to that generally is no, it's not necessary. Do I request it sometime? Yeah, because if I'm in doubt about something, let's say someone is going to have a spinal procedure or what I'm going to operate on, I want to do a comparison before and after, or they've got or they're going to have a spinal anesthetic for some reason, and we really want to know, is it belt and bracelet that is good flow across the craniocervical junction? Then I think there are indications for doing flow studies. but as a routine on everybody, as is becoming common in very advanced health systems, which are lucrative and private, then my answer to that still is no, it's not necessary. But an MRI of the brain, an entire spine, is indicated for all symptomatic Chiari, to look at whether there's syrinx, whether there's hydrocephalus, whether there's a tethered cord and such things. And only do imaging of the spine in terms of dynamic imaging, flexion extension, or CT or MR if you suspect instability. And in conclusion, therefore, Chiari-1 malformation is not a disease. It's a definition that remains vague and anatomical. It's most often incidental finding in the modern practice in the developed countries. It can be a manifestation and not a primary detection. So therefore, beware of hydrocephalus and raised ICP and tethered cord and syrinx and craniocervical anomalies. So don't treat it as the primary finding, because it could be a secondary to one of these, which is the most important thing from a neurosurgical perspective. It's like medical student stuff, really, or basic examination stuff. If you see a signal Chiari, say, is there hydrocephalus? Is there raised ICP? Is there a tethered cord? Is there a syrinx? And any other anomaly, craniocervical junction, and that's it. And you've done your primary workup radiologically. When clinically significant, you've got to think, is it low-lying and impacted tonsils? What's the CSF spaces like? And is there reduced flow, which will help you to kind of judge its severity. Investigation for symptomatic cases, as we've already said, is an MRI of the brain, MRI entire spine. If you suspect instability, then do some dynamic imaging. Remember that children can grow out of Chiari-1 malformation, and the syrinx can improve spontaneously. This is an important message. Can a syrinx if you like, improve spontaneously? The answer is yes. Do the vast majority improve spontaneously? No, but they can do. And they said you don't necessarily need operation or intervention just because it's there. You can have someone with a syrinx who's quite well, no significant symptoms, and you can monitor them. I'm not saying that's the common practice, that's what should be done. I am alarmed when I see a syrinx with Chiari, and I tend to offer intervention, but it's not absolute that it's imperative. Patients clearly can opt not to have intervention. Once again, the Chiari malformation is not associated with sudden deterioration or sudden death. The only time this is not the case is in severe major head injury causing raised ICP, and the other scenario is following severe meningitis with raised ICP and someone having a lumbar puncture. And there's no danger but natural childbirth. Important to say, to treat the cause, if uncertain, do ICP monitoring, and surgery for Chiari should be the last resort. Should be the last resort, whichever operation you use. I think we'll stop there at the moment. I hope that was enough for the first stage. The next stage is the operative techniques, which should be more fun. Anything to discuss, Rafi?
Well, thank you for your presentation. I wish to just throw in one or two comments and ask a question.
Sure.
Can you hear me?
Hello?
Go ahead, Daddy.
Can you hear me? Okay, thank you for your presentation, and just a few issues I needed to raise. And the first being the issue of nomenclature, disease, Chiari disease, Chiari manifestation, Chiari malformation. And it makes me kind of get concerned, because sometimes this becomes an issue when we talk about secondary Chiari, which is induced by either a procedure or something going on. How do you go about this? Secondly, I wanted to ask you if you have a specific protocol for syrinx, and what do you do if you find it, and have you found that often where there is a coexistence of hydrocephalus with a syrinx, and what do you do, bearing in mind that some syrinx may resolve spontaneously? Thank you.
No problem. Most welcome. I'm sorry, there was a bit of interference, but I think if I heard correctly, you had some concerns about the nomenclature. I'm sorry if it sounded a bit confusing, but I agree with you. If your sentiment is that it's not a disease, it isn't. a Chiari is a still remains a vague label, but it's an anatomical definition, and very few things are really a disease. And I think it's absolutely right that it's a manifestation sometime of underlying other causes, and sometimes just purely incidentally detected because of the beautiful way some of us are made, and that's it. It's not a problem at all. It can be just left alone. Your question regarding syrinx and hydrocephalus, is there a protocol? Yeah, generally there's a good guidance, but I don't have a chart to kind of right now share with you. But if you see a syrinx, it is alarming. It's not healthy. And it doesn't mean that the patient is doomed to deterioration, no. But absolutely, we should look for underlying cause. So the first thing to do is to see and examine the patient. Have they got any symptoms or signs related to it? Do they have any sensory motor symptoms? Any spinothalamic involvement? What are the reflexes like? The first thing, as you know, that goes is the abdominal reflex, quite often as a very early sign. And to be able to document and chart what the patient has got in terms of symptoms and any neurological findings, any brisk reflexes and so on. And then you chart that and document what the patient's like at the time. And then you also have to have appropriate imaging. The appropriate imaging, which is mandatory, is image the head hydrocephalus, which should be treated generally if there's a syrinx and any obstruction to the flow, for example, a Chiari, but not always needs treatment. And of course, do a contrast-enhanced MRI scan. Contrast-enhanced MRI scan to rule out any underlying primary spinal, intradural, intraparenchymal pathology. And other things that can, of course, cause it is even, for example, a vascular anomaly or a durovenous fistula. So, and then once you've ruled out you've treated the underlying cause, if the patient's got a symptomatic syrinx or a syrinx which is growing, and if there's none of that, no underlying cause, then as I put, the treatment protocol is you can drain the syrinx directly, and you can do syringo pleural shunt, syringo subarachnoid shunt. There's the Williams procedure, and it all depends what the objective is and what the pathology looks like and the imaging and the underlying cause. And you can even treat some syrinxes with just simply a lumbar puncture, series of lumbar punctures, which can help in symptomatic syrinxes if you don't want to drain the syrinx itself. So, and sometimes just CSF diversion, whether it's a VP shunt or a lumbar peritoneal shunt, can be a good idea. We are talking about fine print stuff now, because I can't give it to you in one short sentence or a short presentation, but there is a good monologue of this, and I can share that with you. And there's a good sessions and literature on this, particularly from Graham Flint on this, and we can share that later on with you. But essentially, not all syrinx needs treatment. It's detection of the underlying cause, treatment of the underlying cause, particularly if it's a worrying cause, like an intradural, intraparenchymal pathology, and surveillance for a syrinx which is of significant size or symptomatic, at least, if not intervention. And intervention on the lines which we discussed.
Mansoor, thanks. This has been a great talk. I've had a lot of compliments from the chaps listening, which is always nice to see. And I mean, the physiology for this is obviously important, and not everything is understood, as you're pointing out. But I think, yeah, you need to grasp on the theories to sort of start understanding how to treat it, and it varies a lot, doesn't it? And just from a practical sense, I mean, for me personally, when I see a Chiari and I'm sort of working it up as a standard, I would be getting imaging for the brain to rule out, as you said, something. I'm just like thinking about a practical take-home message for some of the guys. I'd always get brain imaging to rule out something compressive, which is pretty much routine now, and a whole spine to rule out a tethering or something down below, and I guess in the rare instance of hypotension. Or CSF leak. Would that be sort of accurate? And the other thing, as we've spoken about a lot, is if there is any query at all from the supratentorial compartment, then I tend to think about doing an ICP monitor. Do you have any comments on all of those? And there's a couple of questions from the guys. I'll pass them on when I hear comments on that.
Okay, I think there's a few questions, quite a lot of questions there. I can read them. I'm just trying to focus on what you're saying in the question, but What you said about take-home messages and imaging is absolutely right, and ICP monitoring I'll come back to again. So once again, it's if you get a referral for someone with a Chiari, is see the patient, but this is one case, particularly in the modern industrialized world where so many of these incidental, look at the scan and see how severe it is. How much descent of the cerebellar tonsil have you got? Is there CSF space around it? And so if it's low cerebellar tonsil descent, not 5 millimeters or less, and particularly if there's no deformity, impaction, and beaking, particularly if there's if there's good CSF space around there, highly unlikely this patient requires anything. And important to look at what symptoms the patient got, if any. If you've got a significant Chiari, that is CSF space obliteration or the descent to the tonsils is more than 5 millimeters and it looks deformed and it just looks severe, and or the patient is symptomatic, then I would do, and we've got a paper coming out on this, imaging of the brain, entire brain, to make sure there's no hydrocephalus underlying cause, and the entire spine.
Okay.
And that would be minimum. But certainly not all patients with cerebellar tonsillar descent 5 millimeters beyond the foramen magnum require entire brain and spine MRI. No.
So only when relevant, basically. Also, we've got a couple of questions from our colleague Carlos in Spain. And first of all, he's asking about, do you have any comments about the change in the classification of Chiaris? I don't know if you mentioned that in the beginning, probably. Well, you mentioned what you felt was significant, but any comments about the change in the naming of what's a Chiari 1 and a Chiari 0 and all the rest of it?
Yeah, there's a lot of grievances, and I think this needs to be sorted out. And by grievances, we meaning the classification of Chiari 0. If anyone's mentioned that, Chiari 0 refers to a group of subset of patients, and please bear with me on this because there is some controversy here and a personal disagreements with this as well. Patients who have symptoms, so cough, headaches, and a whole range of potential sensorimotor symptoms, but haven't got a cerebellar tonsillar descent of 5 millimeters. It might be just 2 millimeters or 3 or not significant. But if they have surgery and decompression, they get better. Now, I haven't come across such patients because we don't tend to do that kind of surgery in the United Kingdom. And when I've had my arm twisted to do that, I've regretted it. But the patient accepted the risks and so on and so forth, and it was an MDT combined decision as a group. And I think that's personal experience. And I don't agree with this Chiari 0. I have a hard time accepting it. Furthermore, and please reflect on this, it's very easy to say someone's symptoms could be attributable to a very benign, common anatomical finding. And then you do, for example, a bony decompression and they get a bit better. I have a hard time accepting this. What we need is good studies, scientific data and information, randomized trial or a good trial to show the benefits. And that is severely lacking in Chiari 0 for sure. Chiari 1.5 is, it's a description. I'm not sure if it's really that helpful, but certainly what we need to do is do better for classifying the severity of Chiari. And I know Paolo Bolognesi has published on this and others to try and come up with longer classification as a quick, short, sharp way of describing the severity of the Chiari 1 malformation. Now, we're going to work together to try and improve on this by having a simple classification, which will look at degree of descent, impaction degree, so whether there's beaking, deformity, asymmetry of the tonsils, and whether there's CSF space obliteration. I think these would be 3 key features to look at. And these 3...
There's a lot more that meets the eye as with anything else, isn't there? That it's not just the pure millimeters.
Absolutely. But the problem is that you know yourself, as all the colleagues know, that what makes a classification attractive is if it's simple and short. Yeah. So for example, if you look at Hakim's triad for NPH, why everyone knows it is because it's just a triad, gait, incontinence, cognition, dementia. But if you're going to throw in classification that is let's say pick a spinal one about classification of indications for spinal decompression in the tumor, as you've described. How many there are? There's quite a few. And people, if you ask them, can you remember, give me the breakdown of the scoring system for this? The more the scoring system, the more complex it gets, the more reluctance to use it.
True.
So that's not to say we shouldn't justify good measurements and criteria, but it has to be justifiable to say, okay, I'm even going to use a calculator here on basis of a complex scoring system to score something which is relevant for this patient. But it has to be scientifically based, and that is still lacking and very difficult to derive on that. But I think these three features on Chiari on Chiari 1 will be relevant. We could talk a lot more about this because there's so much done on classifications and the scoring. I mean, for example, why is it 5 millimeters? Why is it not 4? Why is it not 7?
I mean, with all of these things, they're somewhat arbitrary. The more you look at them and understand it, the less you know, it seems. We got another question from Gerald Musa, also, who's asking a more theoretical one, which is if somebody has cerebellar descent and a Chiari 1, he's asking if they would be at higher risk of early brainstem compression in the event of a high ICP from any other reason. I guess that's probably yes, but not so much relevant clinically, because if there is something which is going to be causing that compression, it's going to show up anyway. Or so, have any comments on that?
Yeah, so I know of 2 cases where, and one of them medical legally, and Marcus Studley from Australia, we'll get together, and he's quite an expert on this in the Southern Hemisphere in Australia. Marcus is excellent on this. He knows of several more that have come medical legally where patients have deteriorated rapidly acutely with a Chiari. And as I said, it's only happened in 2 scenarios. One, if the ICP has gone up really high for any reason, such as acute trauma pushing up the pressure. And the other one is bacterial meningitis, which has caused raised pressure within the head, and then they've had a lumbar puncture, which has obviously made a Chiari even worse to kind of cause coning and impaction. So we should be aware of when someone has got a significant Chiari radiologically. I'm not talking a little bit of descent and there's plenty of CSF space. I'm talking about when there's beaking and there's degree of impaction, and you're worried about any other cause of raised ICP. So do beware. But the 2 scenarios I know of medical legally and in the literature that I've presented is only those that I've mentioned.
Okay, that's fantastic. So I think we can wrap up today, John. Thank you, Monzo. That's a great talk. And we've decided that next Thursday, 7 p.m. is our usual time, and on this sort of series of talks, and I'll talk about cervical myelopathy and some surgical strategies and principles. That's on Thursday.
Sure, no, that'd be good.
And then on Saturday, have we decided yet? We haven't decided yet on Saturday.
Well, I'll consult with John. I'm quite keen as one individual for Atal to join the operative intervention talk, because that's going to be a presentation hopefully with a lot of pictures and a few videos.
Aim for 7 p.m. Saturday, and we'll send it to him. And if he can make it, that's great. If not, you can always delay it. And
yeah, if you guys could just give me a couple of dates, I'll just tell them.
Yeah, sure. Okay. No, that would be good. And I think that's going to be something more dynamic. And when we talk about operating, that's going to be fun.
So John, give him a date of 7 p.m. next Saturday for Atul, and then Thursday 7 p.m. I'll give cervical myelopathy talk.
Okay.
All right.
We'll take him when he can do it. Just about any time. I mean, he's such a great teacher. Everyone's seen him, right?
Yeah, absolutely. No, it's
really
wonderful.
I'm not a neurosurgeon, but man, what a teacher. But so anyways, thanks a lot, guys. Great job.
Okay. God bless. Take care.
Stick around. I'm going to do a commercial.
Great job. Thank you very much.
Thank you.
God bless.
Okay, stay here. Don't leave. I'm going to do a commercial. Actually,
thank you so much, Dr. John, for organizing.
Yeah, Dr. Daddy. We got to get you a good internet connection.
connection's not the best.
Mansur John.
Who is that?
Hello,
Who's
Mansur John.
identify yourself.
That's a bleeder. That's a bleeder.
This is not, you're not, is that Joanne? Okay, let me show you. Okay, don't go, guys. I want to show you what. Okay, we have every day. Can you see this okay? Can you see it okay?
Yes, yes.
Yeah, okay.
Yes.
This is the wrong date, but I mean, tomorrow's Sunday. We have it at 5 o'clock India time, 1:30 CT. I'm not sure the topics. I know Dr. Goel is speaking at 6, and I'm not sure who's speaking at 5. So that's the next one. So how was that, Joanne, for a commercial? Is that good?
Hi, John.
Yeah, that's good.
Was that good, Joanne? Did you see it?
Yes, it was amazing.
Well,
Like always.
amazing production.
Yes, definitely.
Who's the person with all the echoing noises?
I think that's.
I have no idea. It's not
well,
me.
I can determine it because I mute people one by one, and I hate to say it, Dr. Daddy, but I think it's you.
Daddy. It's Daddy K.
Yeah, Daddy K. I know. I love to see him come in, but I know it's going to be.
We're not on YouTube still, are we, John?
I'm just testing it. I'll unmute him now. Let's see.
We're not on YouTube, are we?
Yeah, we still are on YouTube.
Really?
Yeah, we still are.
But don't do that. I think you just stop the YouTube channel at the same time that we